that mean you don't get vaccinated anymore? You don't do it?
I do. So thanks everyone for coming out on Sunday night. I think it's Sunday, right? Every time you go to one of these meetings, you forget days and times. But it's a pleasure to be with everybody. This is a session titled Transthyretin Amyloid Cardiomyopathy in patients with heart failure, and there are new opportunities, hopefully, to improve patient outcomes. My name is Matt Maurer. I'm the chair. I'd like to thank, obviously, Alnylam Pharmaceuticals for providing the educational grant that supported this effort. I'd like to thank Vox Media for sponsoring the symposium. At your tables, there's a brief pre-symposium questionnaire, and we'd like you to complete that if you could while you're eating right now, and people that come around and collect those really at this time. Please note to receive a credit. You are eligible for credit. Please complete the evaluation form on your seats and return it to the staff at the end of the meeting, so a pre and a post test, if you will. The faculty disclosures are displayed in the handout. Representatives of the slides are also included in your handout, so you can take those with you. If you want to see the presentations online, you can find them at cmeplanet.com. And for questions at the end, we have question cards, so feel free to jot those down. Unfortunately, we don't have mics, and we'll collect those, and we want to address your questions. Any other future programming, if you're interested in, you can go to @CMEplanet on Twitter and other social media to learn about upcoming events. Obviously, as well, I remind you to please silence all your cell phones if you could. So it's my great privilege to be with my colleagues, Dr. Noel Dasgupta from Indiana University, Omar Abou Ezzeddine from the Mayo Clinic, and my good friend Rick Ruberg from Boston Medical Center. And Rick's going to start us off with ATTR-CM red flags and keys to diagnosis.
Thank you. Thanks so much, Matt. And I hope you're all having a wonderful meeting. And you're here on Sunday night still, so that's good. My name is Rick Ruberg from Boston University, and it's my pleasure to kind of set the table for what we're going to be talking about over the next hour and a half while you're enjoying your food. These are my disclosures. And again, I'd like to thank Dr. Maurer and the organizers for inviting me. So over the next 20 minutes, we're going to talk about the nomenclature, epidemiology, and disease mechanisms of amyloidosis. And I recognize a lot of you know this already, so I'll be going over some basics. Then we're going to talk about the clinical red flags, which is kind of the key of this presentation, and how you can recognize cardiac amyloidosis, which you probably do already, but how to maybe enhance your skills. And finally, we'll talk about the diagnostic algorithm that you would follow. So just to remind everybody, amyloid is actually a term derived from the word amylum. It's a Latin word for starch, because the person who discovered it, Rudolf Virchow, actually thought he was looking at sugar or starch, but he actually was looking at protein. So we now understand that amyloid is a protein folding disorder, and it's classified histologically by taking up this stain called Congo red. And you can see at the right of the screen there's an endomyocardial biopsy specimen with the red kind of proteinaceous material in panel A, and it has green birefringence under polarized light in panel B. That's what the pathologist says is amyloid. It doesn't tell you the type of amyloid, doesn't tell you the precursor protein, it just tells you there's amyloid there. And we classify these systemic amyloidoses by the protein that misfolds. Amyloid can cause deposition in multiple different organs and organ systems of the body, including the soft tissue and visceral organs. And the nomenclature is A for amyloid, followed by the precursor abbreviated protein. So there are a lot of protein folding disorders that are very relevant to human disease. You're all familiar with Alzheimer's disease, obviously, and the protein there that misfolds is amyloid beta. Alpha-synuclein misfolds, and that causes LBD, Lewy body dementia, or Parkinson's disease. The systemic amyloidoses are principally caused by misfolding of one of two proteins, either TTR, transthyretin, or immunoglobulin light chain. Now, I don't pretend that you're going to see this, recognize this, but there are over 30 proteins that can misfold as amyloid. But the ones that cause cardiac amyloidosis are really only two. There are a couple other rarer ones, ApoA4, gelsolin, et cetera, but you don't need to know those. You need to know ATTR, which is by far the more important one, and AL in terms of common, and AL more important in terms of it's much more rapidly progressive and causes severe disease. So TTR is divided into two types based upon the genotype of the TTR protein, which we're going to talk about in a minute. Hereditary or wild type being genetically normal. So TTR protein is produced by the liver primarily in circulation. It's also produced in the choroid plexus and in the retina of the eye, but its principal manifestations of systemic disease result from hepatic synthesized TTR. And for different situations, which we're going to go over, that TTR protein, which exists as 4 different identical subunits, breaks apart, misfolds, and aggregates as these long filamentous structures called amyloid that deposit in the heart and cause heart failure, arrhythmia, and other conduction diseases. And there's other different ways, different pathways through which this can occur, but the principal take-home message is that you have to have a high clinical suspicion here, because not only does it cause heart disease, it also causes nervous system disease, peripheral neuropathy, autonomic neuropathy, gastrointestinal disease. If you went to one of the late breakers today, you heard a whole presentation on gastrointestinal outcomes in amyloidosis. It causes dysmotility, early satiety, and musculoskeletal manifestations, which we'll talk about as an early manifestation of disease. So a high level of suspicion, which you now have by having attended this session, is really critical to recognize amyloidosis. The epidemiology of AL amyloidosis is important to understand that it's really a rare disease. Maybe 5,000, 7,500, or maybe at most 10,000 new cases every year diagnosed in the United States. TTR, on the other hand, is much, much more common. Wild-type TTR, maybe 150,000, maybe 200,000. We actually don't know, and it's definitely underdiagnosed. And again, this is why you're here. But it may cause heart failure in up to 10% of men over the age of 60. We'll show you some data on that statistic, as well as 10% of patients with severe aortic stenosis. And the more important unknown here, I think, is variant disease. We know that there are particular variants like the V142I variant, which I'm going to show you in a second. It exists in 3.5% of people who identify as black in the United States. There are over 1 million carriers and maybe 50, 100,000 or more cases, maybe even 150,000 undiagnosed cases. So ATTR amyloidosis results from either wild type, where it's genetically normal, or this hereditary situation where a patient inherits a single nucleotide polymorphism in one of the 4 exons of the TTR gene. And they're abbreviated with the protein and then the substituted protein. So V142I is valine for isoleucine substitution. And the issue here is that it causes cardiac amyloidosis, but also can cause neuropathic disease. And that's one of the unknown unanswered questions in amyloidosis. Why do some TTR variants cause primarily cardiac and some cause neuropathic? But the more common variant V142I, which exists, as you can see there, in 1.5 million people, really causes primarily cardiac disease. And that's really the most important variant you need to know about in the United States. The reason why is because population studies have really demonstrated that this variant is a bad actor. There are 2 important papers published by Senthil Selvaraj at Duke with Scott Solomon at the Brigham that really identified the risk associated with inheriting this allele. So remember, 1.5 million people carry V142I. Carriers actually have an increased risk compared to non-carriers of atrial fibrillation at the age of 65 years, and you can see the curves diverging there. 70 at heart failure, and then at death for 75. So it's very clear. It's like this is like a increasingly significantly penetrant disease. In fact, when you get over the age of 80, there's actually almost a 25% increased risk of death with allele carriers. So this is a bad actor, and there may be 430,000 people of that 1.5 million who are over the age of 50 and at risk for this disease. So recognizing V142I as an important risk variant is critically important. And this particular study suggested that over 1 million years of life are lost because of this particular allele. Dr. Maurer and Matt and I recently published the results of the SCAN-MP study, which is a screening study for cardiac amyloidosis in patients who self-identified as black or Hispanic over the age of 60 with heart failure and a mean wall thickness of 12 millimeters or more. So in other words, the people we see in our clinics who may have hypertensive heart disease. We actually found that amyloidosis was a fairly common cause of heart failure. This is patients recruited from Columbia, Boston University, and Yale University. These are institutions that do a lot of amyloidosis, yet still, even there, we found that the prevalence of cardiac amyloidosis exceeded 10% over the age of 75, and if patients who were black and who were men, the prevalence actually exceeded 15%. That's a pretty common cause of heart failure that was not diagnosed. So we would suggest that based upon these data, any older person who self-identifies as black with heart failure with increased wall thickness, you should really think about amyloidosis, irrespective of whether or not they have hypertension, for example. And we can talk about that in the Q&A. This figure just basically illustrates the way in which amyloidosis can cause this restrictive cardiomyopathy or polyneuropathy. And it's important to understand that these two, as Matt will get into in his presentation, the manifestation of disease up till, I'd say, until recently really dictated what drugs you could take and not take, because indications followed organ manifestation. That's changed somewhat now with the approval of multiple drugs for cardiomyopathy. Now, we understand that amyloidosis increases with age. And so this is a really important study published from the Mayo about 10 years ago, where they looked at people who had died, and they divided them into heart failure patients and controls, and then looked at how much amyloid they had in their hearts. And the black bars there you can see are amyloid patients. And you can see none at the age of 60, but 70, 80, and 90. The prevalence of amyloid in the heart of people who were 90 who died, if they had HFpEF, was almost 60%. So really high. So something about the aging process, particularly in men, those are the blue bars, which you can see are much bigger than the red bars, something about being a man, and we can talk about that in the Q&A, and being an older man predisposes you to the accumulation of misfolded amyloid protein. So important point. And I've mentioned to you that there are multiple system manifestations of amyloid. The cardiovascular manifestations, you're familiar with heart failure, we talked about, conduction disease, the autonomic neuropathy, the gastrointestinal manifestations. We're going to talk a little bit about carpal tunnel syndrome and spinal stenosis, ligamentous deposition of amyloid. You probably learned in medical school that macroglossia and periorbital ecchymosis were amyloid signs. Well, it's true, but for AL amyloidosis. Very, very uncommon in ATTR. So don't wait till that happens. So the point is that you really need to have, as I said, a wide appreciation of what's happening with your patient. And as heart failure docs, you become very kind of comfortable and facile with thinking about the other potential manifestations of disease. So, and I realize I'm moving quickly, and I'm sorry, but I got to stay on time. So what are the red flag symptoms that you should think about? Well, obviously heart failure, number one. What are the echo features? Well, increased wall thickness, we talked about that, even in the context of hypertension, because many of these patients have hypertension as well, or they did until they got amyloid. Abnormal longitudinal strain, I'll show you an image to that. And I already mentioned the aortic stenosis, particularly the low flow, low gradient phenotype, which I think makes sense. Restrictive filling, low flow, low gradient, that makes sense. Cardiac MR, they have increased extracellular volume, increased native T1, and I'll show you an image to that effect. The conduction disease abnormalities we talked about, something that is very helpful is if they have kind of discordant voltage to wall thickness, more commonly seen in AL than ATTR, because again, a lot of these patients have hypertension, but someone who has normal wall voltage on ECG, but like 18 millimeter walls, that's something's not right about that. And of course, anybody who has like pretty significant increased biomarkers without really an explanation, obviously common in heart failure, but you don't usually see like significant elevation in high sensitivity troponin. You see that, you have to think amyloidosis. Extracardiac manifestations, the ligamentous manifestations, tendon rupture, spinal stenosis, bilateral carpal tunnel syndrome. These are really important, and also the presence of coexistent neuropathy. This slide basically illustrates the echo features. None of them, the bottom line about this slide is that these features don't really tell you definitively of amyloid. The apical sparing pattern and longitudinal strain can be helpful, but you can also see that in aortic stenosis and other diseases. So yes, it's great if it's there, but it's not particularly diagnostic in itself. And definitely the echo features don't help you between AL and ATTR. Cardiac MR is great to differentiate amyloid from non-amyloid. Not very good for looking at the type of amyloid, and but it is also good for looking at progression of disease over time. And what you see here are progressively increasing extracellular volume. That's the color diagram on the bottom. And late gadolinium enhancement goes from none to more subendocardial transmural patterns. But cardiac MR can be very helpful, again, to kind of adjudicate, does this patient have amyloid or not? When you start seeing ECVs in excess of 40%, you really have to think amyloid when you get that back on your MRI report. HCM, we heard a lot this morning about HCM in the late breaker with clinical trials. We did this study with the Tufts, now Leahy group, looking at patients who were referred to their HCM center, and we screened them for amyloid. And we found that we didn't find any obstructive patients, which was, I think, very interesting, but 8% of the non-obstructive patients. Small numbers, but I think non-obstructive HCM in an older person, you got to think they could have amyloid. And in this particular case, the strain was really helpful. The patients who had HCM in this particular study had normal strain, but the amyloid patients had abnormal strain. Aortic stenosis, we've talked about this. This is Dr. Maurer's data on the left and data from the UK on the right, basically showing that maybe 10%, it really kind of varies in which cohort you look at, of severe AS patients have amyloidosis. And you can figure that out by doing imaging testing. This is the carpal tunnel story that I mentioned before. This was data from Denmark. That they screened patients who had bilateral carpal tunnel about 5 to 15 years prior, brought them back, looked for amyloidosis, and they found about 20% of men, particularly men over the age of 70, had amyloidosis. So bilateral carpal tunnel syndrome 5-10 years earlier, because of ligamentous amyloid, may actually precede cardiac amyloidosis. And this also informs data. This is data from Matt and his group looking at lumbar spine amyloid. Spinal stenosis, maybe about 35 to 40% of patients who are older have amyloid in their lumbar spine. We see this a lot now, and we can talk about it in the Q&A. Does that mean they're going to get cardiac amyloidosis? This is why we have an NIH grant to try to figure this out that Matt is leading. So the red flag features we've kind of gone over. The patients who have unexplained neuropathy, spinal stenosis, ligamentous disease, and this discordance between ECG voltage and wall thickness, and the other kind of manifestations of disease. You can see them in your slide. So we recognize disease pretty much too late. That's the problem. We need to move ourselves down to a time when these drugs that Dr. Maurer is going to talk about are more effective. So thinking about this as I move into the last part of the talk, how do you make the diagnosis? Well, we use imaging, and this is a nice slide from a review that Sharmila Dorbala wrote a couple of years ago. Echo looks at wall thickness, MRI looks at the space between cells, and there are specific nuclear tracers that we can use to identify amyloidosis. And the one that's been most commonly used is a technetium tracer in the United States called PYP, and in Europe they use DPD, and in the US we can also use something called HMDP. And this is the consensus guideline that Matt and I both helped write, but basically says how do you proceed through the diagnostic pathway. So if you think someone might have amyloid for whatever reason, first you screen them for monoclonal protein, which I'm going to show you in a second. That's how you rule out AL amyloidosis. And then you test them, if they don't have a monoclonal protein, for amyloid using PYP imaging. And if they've got a specific uptake, grade 2 or more, you can diagnose them with amyloidosis if their light chain testing is negative. And this is what the images look like. Grade 0, no uptake. Patient does not have ATTR, most likely. Grade 3, lots of uptake. They probably have ATTR, most likely. And in the middle, it becomes a little bit more equivocal. The right way to do it is to do SPECT CT, but the key here is they really can't have evidence of a plasma cell disorder, because if they do, it becomes difficult to interpret the nuclear imaging. And so this is a nice paper that Matt Hanna wrote that Matt and I both participated in a number of years ago with Martha Grogan, that basically kind of puts together how you interpret these light chains. So if the free light chain ratio, capital lambda light chains, is normal, and the immunofixation electrophoresis on the serum and the urine is normal, and the PYP is positive, they got ATTR, and you don't need to do any more biopsy. But when they start getting mixed is when it gets challenging, and that's when potentially you might seek consultation from an amyloid expert or your hematology colleagues. One point is that about light chain is that lambda light chain abnormalities should always be pursued because they tend to be more likely to be AL. About 70% of AL amyloidosis are lambda light chain. But kappa light chain, because it's just cleared by the urine, can be higher than the upper limit of normal. And now we have age and EGFR corrected ranges. And there's a recent publication in Circ Imaging just about this that really helps kind of refine its understanding. So this is where hematology consultation can be helpful. So this is data from Dr. Abou Ezzeddine, and he can speak more about it if you have questions in the Q&A. But he looked at the data from Mayo and put together really, I think, easy to obtain clinical predictors for when a patient has a likelihood that you should proceed to screening for amyloidosis. And you can see age is the main driver there, and so is sex. So if you're an 80-year-old man, you are already at a score of 6, which basically says to me, all 80-year-old men with heart failure, I should think about amyloidosis and maybe even screen them. And if you have hypertension, EF less than 60%, wall thickness, and relative wall thickness, an echocardiographic measure, you should think about this disease. And very easy predictor. We are working on validating that in the SCAN-MP cohort. And again, Omar can tell you more about it. But really well calibrated. It works in high and low prevalence cohorts, and I think is a really great contribution to the literature. What about artificial intelligence? You've heard a lot about that at this meeting, and these are ways in which you can use AI to, for example, look at an ECG. One way can look at the ECG tracing itself, and the other way is to use the metadata that is actually collected that gives rise to this tracing. Again, these are data from Mayo. They have an algorithm that was developed. There's actually a product that's seeking FDA registration, and we're participating in a validation of that at our center. That basically is really quite helpful at identifying whether patients, again, reach a particular threshold to identify amyloidosis. These are data from Martha Grogan at the right of the screen showing the years before diagnosis and the threshold. And you can see that the ECG algorithm said no, 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 and then all of a sudden it got above the threshold, and then the patient was diagnosed with AL a couple of years later. But if you had that algorithm, you could have picked up this patient maybe 2 or 3 years earlier and maybe made a difference in that patient's care trajectory. Echo and AI. So this is a space that I've become really interested in recently. You're probably familiar with the Ultramics platform. It's FDA approved. They have a couple of different algorithms that they run. Single loop 4-chamber ECG, echo. They will tell you, this algorithm will tell you a probability of HFpEF just based upon a 4-chamber echo. And they also have an amyloid discriminator as well, which they have recently reported in the European Heart Journal. And again, Matt and I are a part of this study. Multi-center, Jeremy Slivnik from University of Chicago led this study. It was an amazing study, and the senior author was Patty Pellica from Mayo, where they basically looked at a huge cohort of patients from all over the world, largely from the United States, with different diseases, HCM, amyloid, hypertensive heart disease, and were able to validate that this algorithm has excellent discriminative capacity. You can see there AUC of 0.93. With 85% sensitivity. So this may be useful when it gets to prime time, that your echocardiographer is going to say, the Ultramics classifier says could be amyloid, we should move on and test this patient. And finally, I want to talk about nuclear imaging. There's a tracer that's being evaluated now in a study called REVEAL, called evazametide, which is a PET tracer, which is specific for amyloid. Now, I didn't mention that PYP is the, quote, gold standard, but we don't know how it works. We actually don't know why PYP binds to amyloid. We have some ideas, but this tracer was rationally designed by a very, very insightful scientist named John Wall, and now is a product that is being tested for amyloid. And the cool thing about this is that it identifies amyloid when PYP doesn't. So these are data again from Matt, and there are a couple other papers that were published where you can actually see that data table. See, if you can see the grade 0 PYPs or grade 1s, those are all people who would be negative. They would be negative by the current algorithm, but many of them have amyloid by biopsy and were yes by the PET scan. So the PET scan may supplant the PYP as the gold standard for non-invasive amyloid diagnosis. More to come on that, and the phase 3 study I hope will be completed sometime next year. So I know I'm a little bit over time, but I want to make sure that you all understand that you've got to think about cardiac amyloidosis. Again, you're here, so you're going to do that. And anybody over the age of 60 with heart failure, particularly over the age of 80, if you're a man, if you're over age 75 and you happen to be a black man, you really have to think about amyloidosis. And the testing paradigm has really evolved from this tissue biopsy that we did for everybody to non-invasive SPECT diagnosis to cardiac MRI and PET. That's where we're really, and I didn't even mention the AI, and that's the last point. AI support tools are going to be really helpful to us as clinicians to help identify who are the highest risk people and who should we proceed with further testing. So with that, I'd like to thank you for your attention, and I'm sorry for moving quickly.
So thanks, Rick. That was fantastic, as always. Maybe we can pull up my slides, and I'm going to talk to you a little bit about the emerging treatment paradigms. Maybe not. Oh, there we go. So here are my disclosures. And I think this disease, at least in the last 5 or 10 years, has really shifted quite a bit, which we tried to outline recently. TTR is clearly the most common type of the disorder. We're now seeing a much more heterogeneous phenotype. This was thought to be a rare disease, and I think it's bordering on not being rare. As Rick highlighted, we can diagnose most patients without a need for a biopsy. And the big challenge, I think, here in the clinic is there are lots of very effective treatments, which is great. I don't know if it's a challenge, but an opportunity. And these are data from our center that we published in 2001 to 2013, the first bar all the way to the left. We saw a total of 101 patients with amyloid, and everyone in blue needed a biopsy. You can see in a much shorter time period, we saw 215 people. Now we see like 250 new patients a year. and very few patients, less than 10% nowadays, need a biopsy. The staging of patients has dramatically improved. So in gray is what we call the Columbia score, late phase patients, and less than 10% have late phase disease. And we're using, at this study, lots of disease modifying therapy. And that's resulted both earlier diagnosis and the effective therapies in an amazing improvement in survival. I mean, we had a median survival of 2.5 years in the earlier phase of treating patients. Now we haven't reached median survival at 5 years, and I expect it to be somewhere greater than 7. The phenotype of this disorder is shown here. Here's an echo in which the ventricular chamber is essentially non-existent and the atrium are bigger. And this results in an upward shift in the end diastolic pressure-volume relationship, such that stroke volume declines and the body's not happy with the low output, so it activates neurohormones and increases, if you will, the filling pressure in order to compensate for the reduced stroke volume and reduced cardiac output. If you understand this kind of a physiology of this upward shift in the EDPVR resulting over time in a lower cardiac output and a lower blood pressure, just with regard to medical therapy, you begin to realize that there may be a role in certain patients for not continuing optimal, if you will, or neurohormonal antagonists. They're hypotensive and they're not feeling well. And so we'll spend a little bit of time right now just talking about what are the challenges and effectiveness of guideline-directed medical therapy. These patients have a fixed stroke volume, they have conduction disorders and autonomic dysfunction, they often have a fragile fluid homeostasis and a decreased functional capacity. And we don't have really good data to drive the management, but in general I would say that SGLT2s and MRAs, based on data I'll show you, have emerged as very effective therapies, and there's questions I think about ACE inhibitors, ARNIs, and beta blockers. These are data from our center many years ago in very sick amyloid patients, many of whom were being treated with both beta blockers and ACE inhibitors, and you can see the survival curves don't differ whether they were getting an ACE inhibitor or a beta blocker. But to his credit, and Richard Cheng and Wayne Levy looked at patients who we removed the high-dose Coreg typically from. We withdrew their beta blocker, and you can see in blue, they actually lived longer than the patients who were getting the beta blocker. And so in patients with certainly advanced disease, be cautious if they feel pretty miserable and terrible about high-dose vasodilatory beta blockers. Additional data has come from Mariana and her group in London, and you can see they corroborated that ACE inhibitors and ARBs had no clinical benefit. Beta blockers, notably in patients who had an EF less than 40, who were given low-dose beta blockers. Bisoprolol, 2.5 milligrams, nothing more. In this study, was associated with a mortality benefit. And so in someone with a low EF, you may want to pause about removing their beta blocker. And MRAs across the spectrum of ejection fraction were effective. There's a very good rationale for using SGLT2 inhibitors. These are data, again, from our center showing the more diuretics people get, the worse they do. We know that SGLT2s can help and maintain euvolemia and maybe reducing the diuretic dose. And these are data done by one of our med students at the time, who's now a resident at MGH, in which we showed in a non-randomized fashion that the patient who got SGLT2 inhibitors had a marked decline in their diuretic dose and their weight, despite using less diuretics, and their renal function was maintained. Mariana and her group showed in this propensity-matched analysis published in JACC, 200 patients who received SGLT2 inhibitors who were matched to 200 similar patients on propensity matching many different variables, that there are marked improvements in all-cause mortality, CV mortality, heart failure hospitalizations, and the combination of those events. So it looks like, again, SGLT2 inhibitors and MRAs are quite beneficial. The beta blocker story, to further elucidate, about up to 30% end up withdrawing beta blockers because of fatigue or syncope, as I said. And there are certainly multiple challenges to administering them, right? Conduction disorders, there's chronotropic incompetence and autonomic dysfunction in these patients along with their fixed stroke volumes. ARBs have an even higher rate of discontinuation, usually due to hypotension. And again, it's probably related to the autonomic dysfunction and a decreased functional capacity in these particular patients with this fixed stroke volume. But the MRAs and SGLT2s are, I think, something that is becoming, if you will, almost standard of care without good randomized double-blind clinical trial data. I don't know if that will ever come in these particular patients, and something that I think has dramatically improved their outcomes, and we can talk about it further. The real excitement, obviously, in the field is not just using guideline-directed medical therapy, but looking at ways to treat transthyretin amyloid. There are three basic approaches. You can shut off the protein production with either an antisense small interfering RNA, or maybe in the future with gene editing. You can stabilize the tetramer with tafamidis or acoramidis as FDA-approved therapies, and maybe we'll see removal of amyloid fibrils in the future with several compounds in late-phase clinical trials. This is the tafamidis data, which you've all seen over the years. To remind you, a small study of 441 patients, 60% randomized to 2 doses of tafamidis versus placebo. The always striking thing to me about this study was that these patients have very low stroke volumes, very high NT-proBNPs, seemingly like they should be really feeling pretty terrible with stroke volume indexes of like 25 mLs per meter squared. They're kind of in subclinical shock, but they have NYHA class 2 symptoms. And that just means to me that we have a slowly progressive disorder and a good opportunity for clinicians to identify these folks pretty well. The drug was highly effective. We used this technique called Finkelstein-Schoenfeld, or the win ratio, but the absolute difference in mortality was 13% in this trial, which is not what we typically see. No one seems to understand Finkelstein-Schoenfeld or win ratios, so we went back to traditional Kaplan-Meier curves, and you can see there was a 30% reduction in the risk of all-cause mortality that was statistically significant and kind of surprised us in this particular trial. Also, tafamidis was associated with a reduced risk of CV hospitalizations. That was about 33% reduction. The biggest, I think, message from the trial, besides the drug work, was that earlier is better. These are the large, wide confidence intervals, just focus on the point estimates, but you can see for the very few patients in the trial, less than 10% that we were lucky enough to identify with New York Heart Class 1 symptoms, they had a point estimate of 64% reduction in mortality. It was only 39% in Class 2 and 16% in Class 3. So we've all learned that earlier the better for these patients. In the real world, tafamidis data, this is looking at TAUS, looks quite effective out to, at this point, 42 months with overall survival about 77%. The next kid on the block, which is a fantastic drug as well, is acoramidis, a TTR stabilizer as well that mimics the T119M super stabilizing variant. And in this trial, they used a Finkelstein-Schoenfeld with 4 hierarchies. And again, I think the important is the death from any cause or CV-related hospitalizations. The 2 most important parts of the hierarchy were statistically significant, and they accounted for 58% of all the wins. And we've learned with stabilizers that when you administer these drugs, TTR or prealbumin levels tend to shoot up. And that's, I think, a very effective thing to show a patient, honestly, who's worried, is this drug actually working? Because sometimes they don't feel any different. This trial had less mortality, obviously, than the ATTRACT trial, but even in long-term outcomes, we were able to show in a publication by Dan Judge that mortality in cardiovascular hospitalizations continued to diverge, and there was an important signal, if you will, of efficacy with a longer-term follow-up on that endpoint of mortality. Looking at the trial a little bit further, there was early separation of the curves using all-cause mortality in a time to first cardiovascular event, mainly driven by cardiovascular events, not mortality, but 36% reduction in all-cause or first CV hospitalization, a 42% reduction in all-cause mortality in recurrent events, and the annual cardiovascular hospitalization rate was pretty unbelievable at a 50% reduction in this population with NNTs that are really quite small for most therapies. So we have 2 effective, if you will, stabilizers on the market. We have many approaches that are emerging to silence or shut off the protein production. We have smaller interfering RNA, antisense, and maybe one day even gene therapy to be on the market. We're testing that now. So the hypothesis here, which is now, I say, no longer a hypothesis, but been proven, is that you're making a bad protein, either wild type or variant. It's unstable, it breaks apart, it deposits in the organ and causes the phenotype. And by shutting off or reducing the unstable circulating tetramer, you could prevent, if you will, organ deposition of both monomers and amyloid fibrils. We hope stabilize and maybe even potentially reverse the phenotype. So the HELIOS-B trial design is shown here. Mariana Fontana presented this last year at ESC, a randomized double-blind trial looking at vutrisiran, a subcutaneous silencer administered every 3 months in a cohort of patients who were elderly with both wild type and variant disease, but also highly pretreated with tafamidis. 40% of the patients were on tafamidis at baseline, and another about 20% had tafamidis in drop-in during this trial. And this trial also was successful. I give testament to my basic science colleagues. It's not like we're the greatest clinical trialists in the world, but once they figure out a disease like this and they figure out the biology, seemingly almost everything works, which is really great for us and for patients. So this had a 28% reduction in the relative risk of both all-cause mortality and CV events, and a 33% relative risk reduction. That was in the overall population, and then there were people who did not receive tafamidis or monotherapy, where it had a 33% reduction. So quite effective. These are the Kaplan-Meier curves from the original trial, looking at in the overall and monotherapy population, the mortality curves. And again, you can see 35% and 34% reductions in the overall and monotherapy group. So a drug that not only prevents hospitalizations, but as well, like others, saves lives. We've done some subgroup analysis in this particular trial. These are data looking at the severity of heart failure, if you will, class 1, 2, and 3. And NT-proBNPs above or below 2,000 is how we stratified things. And we look both at all-cause mortality and recurrent events, or all-cause mortality. And you can see there's really a lack of heterogeneity across the spectrum of heart failure severity. Though I would note that this trial, in those who had NYHA class 3, did not have, if you will, NAC stage 3. So it's not the full spectrum of NYHA class 3 patients. This drug also decreased the risk of what we call urgent heart failure visits by 46%, and also decreased the risk of other cardiovascular events and mortality, as we recently just showed and described. So quite effective. And it's interesting, but in this trial, we looked very carefully at trajectories, if you will, of biomarkers. This is NT-proBNP in the overall population on the left and monotherapy population on the right, and the same for troponin. And you can see that the administration of vutrisiran tend to ameliorate any rise in the biomarkers that we were seeing, which we found quite interesting. And in fact, for some of the biomarkers, you can see troponin I, there looks like there was a decrease in the values over time, indicative potentially of less myocardial injury or damage. I think we spend a lot of time talking about things that are not very applicable to patients, right? I mean, mortality is in CV hospitalizations, but what patients care a lot about is what's their functional capacity at the age of 80? Can they play with their grandchildren? Can they visit their family members? And what is their quality of life? And this publication by Farouk Sheikh was really important. Also in JACC this year, looking at 6-minute hall walk and the KCCQ. And there was, again, statistically significant effects on all of these endpoints, but there were even improvements that we saw in small cohorts of patients from baseline, which we didn't see with other therapies. So now we have 3 therapies, and what is one to do? And I don't have answers, I'll tell you right away. So if you're expecting me to, we could always pose questions. So with Pablo Garcia-Pavia and Esther Gonzalez, we wrote this review about precision medicine in cardiology and where we've been. And so what is the initial therapy according to the patient profile? Should we switch from one therapy to another? If you're giving a silencer, should you stop a stabilizer? Is there any long-term safety issues? What are the financial burdens of these drugs to patients? There's any role for combination treatment? What are we going to do for asymptomatic or early patients? And these are all questions that occur in the absence of any definitive head-to-head comparisons. So I'll try to explain to you how we tried to address this in a recent article that we published in JACC Heart Failure, just looking at the data. Transparently, you can see these are the 3 trials, still not very large, but important in amyloid, conducted in markedly different eras. The age of the patient stays the same. The amount of variant patients has gone down. That is not, in my opinion, a good thing. We need to work harder at engaging and getting variant patients, who are particularly usually African Americans in the United States. But everyone in the room has done a fantastic job at finding people at an earlier stage of disease, because look at the placebo mortality, no therapy across all 3 trials, and it's plummeted, as has the cardiovascular event rate. And the New York Heart class has improved as well, and the NT-proBNP has gone down. So these are very hard to compare across trials. Brett Sperry put forth this really nice picture. And I think the most important thing is just to look at the placebo arms and see how much people are improving. And that's not due to any drug therapy. That's just due to, again, excellent clinicians out there thinking about this disorder and finding people early. And I can't thank you, and I'm sure your patients can't thank you enough, because these drugs definitely work better when given earlier. But if you were to look at each of these trials at the risk reduction with regard to hazard ratio on mortality or CV events, or if you start to look at the differences at baseline to follow up at 30 months in either KCCQ or 6-minute hall walk, you can see here the point estimates, and we put the 95% confidence intervals in there. And what I conclude from all this is all the drugs work, and there's no evidence of any superiority at this particular point in time. The confidence intervals are all overlapping. And so what's one to do? I can not tell you what you should do, but I can tell you what I do. I try to have a process of what I call shared decision-making, which makes the visits quite a bit longer nowadays for those of you who practice in amyloid, because a lot of questions. To be clear, shared decision-making, in my opinion, is not I made a decision and I shared my decision with the patient, okay? That's not shared decision-making. Shared decision-making is, a collaborative process where you actually usually come clean, tell the patient, this is the evidence and the data, this is my uncertainties and not uncertainties, and try. And in these discussions, this is kind of, I think, what's evolved. So patients, unbelievably, when they hear that there's not proof of one being much better than another, often talk a lot about mode of administration. Do they want to take a pill, or do they want to get a shot? Do they want to come to the hospital? They want to take a drug once a day or twice a day. They want to come get a drug if they're taking a planotersen for variant disease once a month, or vutrisiran every 3 months. So those are really important decisions for certain people, especially, examples in New York, people are snowbirds. I personally think that, for patients who have variant disease, there's very good evidence that TTR is much more unstable, and so that might factor into your decision-making. And certainly we have, I think, better data for silencers in neuropathy than we do for stabilizers. So with a prominent neuropathy, we would lean toward that. And the most important thing I would say here is that, the key here is getting someone on a therapy and maintaining them on a therapy. You can get into the weeds about which one's better, but that's the most important thing. And so if there's something, preference in their insurance or others, that's where I would move toward. We've become really interested now that we have effective therapies and how they're working, and these are data on disease progression. This is a field in of itself. There's no shortage of disease progression markers. You could spend 3 hours in a clinic on every individual patient trying to make all these measurements. We did that. One of our fellows presented the data in a cohort of patients at Columbia, and it's not surprising when someone progresses with one of these factors, or particularly 2 or more of these factors, their outcomes are worse. Having said all that, I just want to caution everybody that people with this disease may get worse, and it may have nothing to do with TTR biology. They may be getting worse for their worsening heart failure, myocardial scarring, their age, their frailty. And we know from Alzheimer's literature, that's the sigmoidal curve shown in the bottom there, that patients can have a brain that's boatload filled with amyloid, and they continue to have cognitive dysfunction even though they're not getting any more amyloid. And so it's okay, I think, if you want to switch a therapy or add a therapy, but I think you should probably tell the patient that we're not 100% sure that this is going to, at this point in time, improve your outcomes. We just don't know. Whoops. Looks like I'm stuck. Oh, okay. I thought I had a conclusion, but maybe not. So I would say that, I would say to conclude, we're in this very exciting time period and very enviable position. We've moved from having nothing to do for patients 5 or 6 years ago to have a lot of things to do. And I just encourage you all to keep thinking about who's got amyloid, that Dr. Ruberg said, and most importantly, to try to find your patient as early as possible and get them on some therapy that they can stick with. So with that background, I'm pleased to have my colleague, Omar Abou Ezzeddine, come up and give us a case that we can kind of chew on a little bit about amyloidosis.
Thank you so much, Dr. Maurer, and to the organizing group for having me here. It's a privilege to share this stage with my co-speakers. So just to put it all together, I thought I'd present a case and scratch your brains and help me in clinic here. So here are my disclosures. So this is a patient of mine, a 72-year-old gentleman with a history of known HFpEF, who presented with worsening exertional dyspnea and fatigue. This patient was previously quite active, class 1. He exercised a few times a week, he would run, and now all of a sudden, over the course of the last 6 months or so, he has progressive symptoms of class 2 and 3 NYHA symptoms. He's profoundly fatigued and orthostatic. His past medical history is significant for your typical 72-year-old gentleman: hypertension, atrial arrhythmias. He's status post-ablation. He does have sleep apnea. Interestingly, he has bilateral carpal tunnel syndrome and has had those released over 15 years ago. And shown here is his med list. So I'm not sure when the last time you asked your patient to do this in your cardiology clinic, but you should do it more often. He was bradycardic, a bit hypotensive. He did have a bit of a systolic ejection murmur and did have evidence of fluid overload, both central and peripherally as well. These are his biomarkers. He was somewhat anemic with a GFR of 60 or so. His high-secreted troponin T was 73, NT-proBNP around 3,000, and a prealbumin of 7. This was our patient's ECG, and we can't present an ECG anymore without talking about the AI ECG model, because actually at Mayo we get these, and I'm sure other institutions too, on all our patients now. And this patient beat the threshold. He went above the threshold of around 48% or so, and so this ECG was concerning for amyloid heart disease. This is our patient's echocardiogram shown in the upper left quadrant there. This is a parasternal long axis, increased wall thickening, as you see. The center picture there on the top, this is a Mayo Clinic format, so what you're looking at is the left ventricle, some left atrial enlargement. Wall thickness was around 13 to 15 millimeters with increased relative wall thickness that approached 60%. Compromised stroke volume index. So all findings suggestive of an infiltrative process, and he did have a bit of a aortic valve gradient as well. We didn't talk about strain a lot, but cherry on top pattern here shown in the upper right-hand corner, suggesting that there's some infiltrative process that's going on. This patient was referred for a cardiac MRI, which again showed some increased wall thickness. Unfortunately, we didn't have good T1 measures, and the myocardial nulling actually was normal. So this radiologist came back and said, these findings, though could be supportive, they're not quite conclusive for amyloid heart disease. So if we were to calculate this patient's score, which was referred to earlier, he was 72, so that's 3 points. He's a male, he gets 2 points for that. He has a history of hypertension. You actually lose a point for hypertension. EF was less than 60%. You gain a point for that. Posterior wall was more than 12 millimeters, and his relative wall thickness was close to 60. So if you calculate this patient's score, it's quite high at 8. So anything 6 or above is high risk. And so we pursued this with testing. So at Mayo, we tend to do things simultaneously. So we got a PYP scan and we got monoclonal protein studies. I'm going to pause here and ask our panel. What % of patients do you actually order the blood test and then have them come back to do a PYP after, or do you do it at the same time when you order?
Do you want to know? You want to go first?
Oh, I order them at the same time, understanding it's probably going to take, in our lab, they only run them a few times a week for the labs, and then the PYP will probably be done within a week or so. So there's usually some time separation, but I order them all at the same time, understanding I will review them all and determine what to do. Otherwise, there's a time delay, and that's why I don't wait to do it. I want to make sure we can treat people as early as possible.
Yeah.
And the labs will probably come back before they get their PYP.
Yeah, I would agree. I think the key is that you can't forget to do the monoclonal screen. You can't order one without the other. And so the guidelines were written in such a way as to emphasize that that must be done. But I agree with Noel. I order them together. The blood's drawn, the urine's collected. You have those results in a couple days, and the PYP is usually done in a week or two after.
Okay. And do you get fat aspirates on all your patients? What's your practice? I'm just curious.
In cardiology clinic, if I'm seeing them just as a new evaluation, no. But if I suspect, this is just a very BU thing, but if they're suspected to have amyloid, then we will get a fat aspirate. The fat aspirate, though, as you're probably going to say, is not particularly helpful for ATTR, but it is helpful for AL. So if the fat aspirate's negative, it doesn't mean they don't have AL, but it argues against AL because most AL patients, about 70% of them will have a positive fat aspirate. But you still could certainly have isolated cardiac AL with a negative fat. So.
And if you had hereditary TTR, is your fat more likely to be positive, or does it make a difference? I don't know. Is that question, is that known?
Yeah, I think it's probably a little higher, but I don't think we know definitively. But I don't do any fat pad biopsies for like 10 years anymore. Milton used to make fun of me, Packer, all the time when I was doing them, so I stopped.
They're not commonly done. They're not commonly done in like a cardiology clinic. I think it's more amyloid specific. But this case, though, you have like there's a kappa abnormality, and so this could be kappa AL amyloidosis, even though the clinical presentation was very consistent with ATTR wild type, age, ligamentous disease, spontaneous tendon rupture, et cetera.
And the only thing I would add is the pre-albumin of pre-treatment of 7 is very low, and it would make me be very concerned that this person has variant disease on top of it. So all things are on the table at this point, I'm not ready to conclude. I agree with Rick. You have to be very concerned about the light chains, but pre-albumin of 7 often is like, wow.
Very low.
Yeah.
And you might not even, in this case, you might not be able to adjudicate amyloid without tissue. Because of the fact you've got, the guidelines would say you've got a kappa abnormality. You really can't interpret the PYP because, again, if it's grade 0, it's probably not ATTR, but it still could be AL. And we know that a small proportion of patients could even have grade 3 uptake and still have AL. And so small proportion, maybe 10%, but you don't want to miss those patients. So this is somebody you're kind of going in already thinking, I might be going to a heart biopsy, just because it's inconsistent data.
So back to the pre-albumin, do you guys get it on every patient that you're seeing in clinic?
Yes.
Yep.
Okay. So just to touch upon the algorithm that was already presented, when you're studying for boards or whatever, when you're reading the literature, the first step is rule out monoclonal proteins. If you do have monoclonal protein, it's more of an emergency. You need to pick up the phone, call your hematologist. This patient may need a bone marrow biopsy and a more emergent workup. If, however, there is no monoclonal protein and you're suspecting amyloid, then nuclear or cardiac scintigraphy is warranted, and in the absence of a monoclonal protein, a positive PYP scan negates the need for endomyocardial biopsy. Now, caution, if your PYP scan is negative and you're still suspicious, you must do a biopsy. I just want to open it up for the panel. Do you want to talk about your experience with that?
Yeah, Noel, do you want to start?
If my PYP is negative, so there could be different reasons why the PYP was negative. It could be early disease. There's certain hereditary mutations that don't have a positive PYP. Their test could have been done wrong, which can happen. Sometimes they actually give the wrong tracer. I've seen it happen. So there can be different reasons why the PYP could be negative. So usually the first thing I do is to look at the PYP and look at when the timing of everything was given, because I've actually seen a few times the wrong tracer was given. I had to redo that. So actually look at the reports of the timing of everything and then look at all the images myself and see if there was also confirmed on SPECT. And then I look at the whole clinical process and see everything about the patient, and I do a lot of biopsies if I'm not certain and I don't feel like I know the answer. I think it's important to get to the right diagnosis, so I feel like that's the right thing to do biopsy.
Yeah, I agree with Noel. I think a grade 0 PYP usually means it's not ATTR, but there are rare variants like phenylalanine 64, which was very uncommon, but could be no uptake, but still have TTR. But you also might be in the world of, well, it could be AL, obviously, if PYP is negative, so that's in this particular case. But you could be in the world of one of those uncommon ones that I glossed over early on in the presentation. But there are, ApoA4, for example. It exists, and in fact, if this patient was at the NAC, they might consider getting an ApoA4 genotype to screen. We don't commonly do that in our center. But I think that point is absolutely essential, that if you still suspect amyloid and things don't fit, just go for the heart biopsy.
And I worry that over the last few years, we've moved to the non-invasive space so much more. I mean, at the end of the day, it's an imaging test, and it could be falsely negative. So tissue is the issue, and sometimes you must go under the skin to do that, particularly in this case when there's clearly abnormal monoclonal protein, and regardless of what you find on your PYP scan, you need tissue. We have seen cases of both AL and TTR at the same time that were first treated with chemo and then subsequently treated with stabilizers. And so you could have both.
And there are cases of AL that have normal free light chain and immunofixation. Not to make people freak out, but it's really uncommon. Again, this paper that I alluded to from Paolo Milani and Giovanna Palladini that was just published in Circ Imaging like last week. It was a big series from their big center in Italy. It was about 3% of patients with AL actually had normal FLC and normal immunofixation. But they still made the diagnosis because someone was suspicious and went on. So if you suspect, always go forward.
And for me, if I see the person has a monoclonal protein, even in the light chains, I usually talk to one of the hematologists if I'm concerned, and sometimes it would be appropriate to do a bone marrow biopsy and fat pad aspirate, and because that's a little bit less invasive, and then move on to the target organ if you don't get the answer you want. But certainly I do lots of cardiac biopsies or have somebody do them.
And the last thing I'll say is, if this is a nonagenarian, you have to also think about the patient and the risk associated with the procedure. You all do biopsies, you order them. It's a fairly safe procedure, but sometimes bad things happen. And if you're older and frail, those risks are higher. So we'll sometimes make the decision of a best guess based upon all the information we have and not do the heart biopsy if we think that the risk or the patient says absolutely no. Now, I know Matt biopsies a lot more people. We talk about that all the time. But I think, it's just that's practice.
Yeah, so I mean, this patient did have a cardiac MRI. It was a bit sort of not conclusive, Yeah, because it won't tell you what type. You're still right. And so, so your question was why?
Why not, if the PYP is negative, why won't we go to a non-invasive test and then
Use that to judge.
you can do genetic testing, for example, if it's positive?
So that's a great point. You've just basically kind of recapitulated the European guidelines with your question. And that's how MRI is used in the European guidelines. It is, if someone has an MGUS, and you can do the cardiac MRI, and if the cardiac MRI is completely normal, ECV is normal, no late enhancement, then it's probably an MGUS without amyloidosis. In this particular case, the MRI was not normal. And so, but that is exactly how you could use it. You could spare the patient a biopsy because the MRI was normal.
So because of this, this patient was biopsied indeed, and as you can see here, pink amorphous material is suggestive of amyloid, which with Congo red stain under polarized light. This is apple-green birefringence that Rick had referred to earlier. It's not enough. You need to then go to mass spec. So you've identified there's amyloid. You need to actually subtype it. And in this case, it was TTR, which after gene analysis was indeed a variant form of TTR. And going back to Matt, so can you elaborate a bit more about what you had mentioned about the prealbumin?
Yeah, I mean, normal prealbumin's 20 to 40, prealbumin's TTR, and if you have a variant in TTR, your prealbumin's falling apart because it's unstable. And so, in our clinic, we measure prealbumin, and when it comes back, 15 or less, we're like, okay, we often bet that it's going to be a genetic, we wait for the genetic testing, but we don't obviate the genetic testing, but I would be suspicious. Yeah.
He's a little bit old to present with T60A. Like usually it's 40s, 50s. Although we've certainly seen people at that age presenting. I didn't mention this variant because it's not as common as V142I, but this is the variant that was identified in people of Irish descent in the northern part of the Republic of Ireland, and we see it obviously in Boston a fair amount. Maybe less so in Rochester. I don't know, but it also was seen in kind of Appalachia in the United States.
So you're seeing this patient and you have these options. What are you going to pull? Okay, let's pull. Go ahead. Let's see.
For me?
Panel, yeah.
So the first thing, if I knew it was a hereditary patient, I would look for evidence of neuropathy. I actually do a lot of neurologic exams and have a tuning fork and all of that stuff. And I do try to look for neuropathy. So if they have evidence of neuropathy, that might put me more towards a silencer because that's where the data is. If they have a mixed phenotype, like Matt said, I have discussions with everybody, and they're complicated discussions these days, trying to explain to them everything and to try to make a decision. But if they're not very bothered by their neuropathy, if they did have some, then oral therapy if they prefer it. You could make an argument for, and there are patients I have on combination therapy. These are long discussions, and you have to kind of individualize them all.
What's your experience been like with coverage, and have you had any, do you want to elaborate on that a bit more, or Matt, Rick?
I've had fairly good success. I do a lot of appeals, and it's a lot of work. But I talk to the patient and try to figure out between all of us what we decide to do. And I'm willing to do all the paperwork and denials to try to get the therapies they want approved. So I have good success.
Yeah, we didn't talk about cost actually. This is like one of Dr. Maurer's favorite topics. But so vutrisiran costs about $460,000 a list price, I think, per year, and tafamidis is $300, $260, something like that. You're looking at around $750,000 at list price for these drugs when you're on combination therapy. So just so people understand the costs that we're talking about. Now, a lot of people are going to maybe even merit that consideration, but we don't know the answer to that. I think in this case, I think Noel's points are absolutely essential. What is the disease manifestation? Because the silencers were approved until vutrisiran was approved, were approved for neuropathy only. So this patient, if they had neuropathy before vutrisiran was approved for cardiomyopathy, could have gotten possibly vutrisiran. There's another silencer, eplontersen, which is being tested in a big trial called CardioTransform that Matt is the PI of. That'll be in a couple years, something like that.
And
Next
this
year?
is kind of
ESC next year.
ESC next year, you heard
a changing time because this is the first time we have both silencers and stabilizers approved for cardiomyopathy. And so how insurance will look at this is always evolving. So.
I know the VA is all gonna be one and the same price. So that way, but no combination.
What if the patient had wild type here, and a bit younger? Let's say he was a 60-year-old with wild type. Are you more likely?
Yeah, I mean, again, I think at this point we have 3 agents, they all work, and you have to have a discussion with the patient. I agree with Noel, in a variant patient, you really have to consult a neurologist and make sure that they don't have a neuropathy, because this variant is associated mainly with a mixed phenotype.
Sure.
And it's also the patient preference. I mean, so tafamidis is once daily, acoramidis is twice daily, and vutrisiran is an injection every 3 months.
And vitamin A, yeah.
So and vitamin A supplementation, right? So they have to remember that too.
Right.
So I think it really becomes kind of patient preference, and also sometimes we'll actually run a couple of pre-authorizations for all of them and figure out which one is least expensive to the patient, and then let them help them inform their decision.
And what's your follow-up? So let's say you start this patient. So this patient, let's say, was started on a silencer. What's your follow-up plan? When do you see them back typically in your clinics?
I usually see a new patient back within 3 months, not not chronically, but I mean, people are anxious, they're worried. Sometimes they see them even sooner. I'm not sure they're going to get therapy. I invite them back in a month because I don't want this patient to go 3 months without treatment, you know. So, but you know, for a new patient, there's a lot of questions that are evolving. It's better, in my opinion, to see them in person or via telehealth pretty soon and kind of tamp down their anxiety, see how they're responding. That's my approach.
And then after you start therapy?
Yeah, usually depending upon their clinical phenotype. I don't see anyone more than a year's duration in length, but usually every 6 months is what we're seeing patients at our place, if they're stable.
Okay. So after discussion, this patient chose to be on a once-a-day pill for his disease, but did present with worsening heart failure symptoms despite being on all the good drugs that we talked about, and did also start having recurrent atrial arrhythmias, which again, as a reminder to the group, a sign of disease progression Dr. Maurer had referred to. Indeed, described symptoms of neuropathy and was referred to neurology who diagnosed him with that. So at this point, on stabilizer, do you switch him to another stabilizer? Do you add a silencer? Do you just stop the stabilizers and just continue on silencers? What do you guys do? Yeah, what would you do for this patient?
I mean, these are, again, really complicated decisions, and I don't have the right answer, but if they were progressing, I would consider adding a silencer or switching to a silencer. I mean, I always like to go back and see what else is going on with the patient. So my first initial step before adding all these, I mean, I add all the amyloid-specific therapy, but there's a lot of other things that can make the patient worse. So I try to go back to the basics, look at things like arrhythmias, and then look at if there are other medications, non-specific heart failure medications I can take away or add, and a lot of that stuff will improve the patient. So I don't jump to that it's a failure of therapy, but I would certainly consider it, and then what to do next is always a good question. And those are lots of complicated discussions. Yeah.
Those are great points. I think in this particular case, because the patient has neuropathy and there's evidence of progression, I would definitely have the patient on a silencer. Whether that included stabilizer and silencer would be part of a good discussion, but I think a silencer would be appropriate. Also, because again, as I mentioned, like these drugs have been proven to work in neuropathy and also proven to work in this case for Transthyretin and cardiomyopathy, so it would make sense in this particular patient to have them on a silencing agent.
And how do you use serial, do you use serial prealbumin levels to look at response to therapy and to help you make decisions? I'd love to hear your thoughts on that.
With silencers, certainly, because the level should be like less than assay. And so that's how you know that you have efficacy, because you're turning off production about 80% with a silencer. Typically, the prealbumin levels will be like less than 4 milligrams per deciliter or somewhere in that range. So that indicates efficacy. I've had some patients who don't respond, actually, interestingly enough, and that's it's almost like their case reports. But most people will drop their prealbumin down and then hopefully experience the benefits that Matt showed at the individual level. It's a little more complicated with stabilizers, but with silencers, definitely.
Ultimately, this patient was transitioned to vutrisiran, and 6 months later, he's doing well. His biomarkers have stabilized as well, and as did his diuretic requirements. So, just a final plug. Any amyloid clinic should really be multidisciplinary in every sense of the word, from within cardiology, the multiple disciplines, heart rhythm groups, the heart failure group, obviously, hematologists, pathologists. You really need to trust your pathologist and pick up the phone and talk to them about what they're seeing. Neurologists, palliative care, very important. Do you guys involve palliative care in all your patients in the amyloid clinic? How do you approach that?
I think it depends on the individual patient and how they're doing when they present to me. If they're very late stage and it's clear that there's not going to be enough time for therapy to work, or they're not going to be a candidate for an advanced treatment like transplant, then I might do it right away if they're willing. But these, again, are a little bit complicated because some patients don't like having palliative care involved initially, and you have to kind of gain trust. So I try to do it as soon as possible if it's consistent with what the patient wants. But again, it usually involves developing some trust.
And just to clarify, palliative does not always mean end of life. I mean, we've found them very helpful personally. Goals of care discussions, other symptoms that we suck at as cardiologists treating that they excel in. So definitely. Okay, I'm going to open it up for questions. And
I think, yeah. Well, we're a little over time, so I'm just going to do 2 rapid questions. If anyone else has any comments, they feel free to come up after. So one is, does age of diagnosis affect your treatment choice? What is the age of the patient? Anybody?
It does and it doesn't, because the same thing applies for all of the patients to me. So the same discussions occur regardless of your age. I'm not limiting therapies based on age because there are people that are older that have done really well on therapies, so it doesn't affect me directly. But if someone is older and they don't want to get, an injection, or they don't want to go to a place to get it, they might prefer an oral therapy, and that might be less, difficult for them and better for quality of life. So I don't change my conversation, but depending on where they are in their life and what's important to them, sometimes an oral agent might be better for some patients, but not for everybody.
I think also it depends on like other comorbidities as well. I'm sorry, my microphone may be out. But so data-wise, most patients who are over 90 were not included in these trials, right?
Correct.
So there really isn't any data.
Actually excluded. None of them have, everyone who's 91 or above is excluded. There's never been a trial that included people in their 90s. I would still give the drug to them personally, but...
Well, that's the point, right? That's the point. I mean, because the safety profile is so benign, then you're probably getting some benefit. However, if someone has like advanced dementia and is like has a lot of limitations, it's reasonable to have a discussion, as we discussed with the family and the caregivers, about what the goals of care will be. That kind of really makes that more important. And if it's financially not like toxic to patients, it's reasonable to treat. But it becomes more, I think, in advanced aged people, especially with lots of comorbidities, the reflexive decision to treat becomes a little bit more, I think, nuanced.
My oldest patient was 103 that I started therapy on. And maybe finally, what's your recommendation for supplemental vitamin A in silencers? B, do you check vitamin A levels? And C, do you have any concerns about long-term issues with suppressing TTR? So anyone.
Omar can do that.
Definitely, if they're on silencers, they need to be on vitamin A supplements daily, and sometimes that may influence. We've had patients who said, I'd rather be on a pill. If I'm going to be on a pill, I'll just take a pill. Others have said, I'll do an injection, and then you tell them about the vitamin A part. But the vitamin A part is crucial.
Do you measure vitamin A levels in clinic?
I don't.
No.
Me neither, and I would urge you not to, because you're not going to make the vitamin A level normal, despite taking, oral vitamin A, and you're going to make the patient freak out.
You should explain why. I actually didn't explain that in my. I'm sorry, I forgot about that. So, transthyretin is so it's all trans-retinoic acid and thyroid hormone. So TTR is the principal protein that transports vitamin A. So you don't make any TTR, you can't transport vitamin A, which is why you need to take supplementation, but you can't get up to normal range. That's why you take vitamin A, and I probably should have explained that. It does not affect thyroid function at all.
But serum levels don't reflect total body stores, so you can't simply check vitamin A levels and supplement based on that. And there are lots of people who try to, and that could actually lead to vitamin A toxicity. So usually you take a multivitamin, most of them around 3,000 international units a day, but not overdo it. So.
Yeah, great point, because I had just had a patient who sent us a long email in which he's a physician and he was trying to supplement his vitamin A to the point where he could replete it because his levels were low. And then he sent us data, never mind that vitamin A toxicity is bad, that it actually increases your risk in animal models of PVCs and ectopy. And he noted on his pacemaker that he was having a lot more ectopy, couldn't figure out why, and then realized that taking, 25,000 units a day of vitamin A was probably leaning over a few months to a lot of problems. So, you know.
And when you are worried about vitamin A deficiency, you're worried about, like problems with night vision and stuff. So if you're concerned about vitamin A deficiency, you first send the patient to see an ophthalmologist.
And I personally think the concerns about long-term risk are, not that high in my mind. We've been dosing these drugs for 10 years. It's not 30 or 40 years, and we haven't seen any problems with silencers. So I'm hopeful that, long-term therapy will be fine. So.
It's an interesting question. We will find that. We'll find that out.
Well, again, thank you all for coming. Any other questions?